Good morning, everybody. We are going to go ahead and get started with our first scientific session. And our first, my name is Karen Brasel. I'm honored to moderate this first session along with Dr. Scoggins and Dr. Schmidt. And our first presentation is by Elizabeth Lilly. High symptom burden in patients undergoing gastrectomy for cancer. And this is one of our quick shots.
Good morning. Okay, great. Good morning, and thank you for allowing me to present this work. I have no disclosures. Okay. In the West, patients with gastric cancers often present with symptoms that may impair well-being and quality of life, and this can only worsen during neoadjuvant treatment. So as a result of this, patients who are presenting for gastrectomy may have existing high symptom burden even prior to surgery, but there is little data describing gastric cancer patients' symptoms in the perioperative period. Therefore, we sought to quantify the presence of symptoms prior to and in the days after gastrectomy. This prospective descriptive study was performed at an academic cancer center from May 2019 to September 2021. Patients undergoing gastrectomy were identified in clinic prior to surgery and invited to complete the MDAS-EGI, both before surgery and after during their hospital stay. The MDAS-EGI is a validated tool asking patients to rate the severity of 18 symptoms, as well as the global impact of these symptoms on their lives in 6 domains using a 10-point Likert scale. Symptom data were summarized as percentage of patients who reported at least moderate severity symptoms. During the study period, 39 patients completed 94 surveys, 28 prior to surgery, 33 in post-op days 1 through 3, and 33 from post-op days 4 through 7. Prior to surgery, 1 in 4 patients reported moderate to severe fatigue, and 1 in 5 reported moderate to severe sleep disturbance. In the first days after surgery, 70% of patients reported pain, and approximately half of patients were reporting sleep disturbance, dry mouth, fatigue, and drowsiness. During postoperative days 4 through 7, 49% of patients were reporting pain, 41% reported diarrhea, and 36% reported sleep disturbance, at least moderate to severe severity. And while most symptoms initially increased immediately after surgery, then decreased again in postoperative days 4 through 7, bloating, distress, diarrhea, and sadness all increased at both postoperative time points. Prior to surgery, 21% of patients reported moderate to severe impairment in work and enjoyment of life related to their symptom burden. Compared with baseline, the percentage of patients at postoperative days 1 through 3 and 4 through 7 reporting at least moderate impairment increased after surgery in all domains. These results demonstrate that patients undergoing gastrectomy for cancer experience frequent symptoms, which can impact quality of life, both before surgery and after. Routine postoperative care frequently focuses on pain, appetite, and nausea, but other symptoms such as fatigue, sleep disturbance, drowsiness, and distress are common and may be unrecognized and therefore unaddressed by surgical teams. These data can help surgeons to prepare patients and caregivers on what to expect after surgery. Further work is needed to determine how best to screen for and intervene on physical and non-physical symptoms before, during, and after the surgical episode. Thank you.
This paper is now open for questions. I guess I will start. Do you have any information beyond their hospital stay in terms of the MDAS or other measures of quality of life?
Yes, thank you for that question. We have been collecting some data from further out. We have some data even up to a year after surgery, which we're currently analyzing. What's clear to us is that some symptoms don't really return to baseline, and so patients can experience ongoing symptom burden after surgery.
Dr. Swanson.
Hi, good morning. Really interesting study. So a study like this, when you are looking at quality of life, my thought, in addition to preparing the patient for the symptoms after the operation, was there any thought about thinking how to intervene for their symptoms before the operation?
Absolutely. Thank you for that question. So I'll give you, my background is also, besides surgery, is in palliative medicine. And so I think symptom management is really important for these patients. And so there's a few different ways that we can look at this. One is in preoperative supportive care consultations, which some of our patients did receive to help with symptom burden. What's more challenging to track, and what we have not yet studied, is which of these symptoms are the most distressing or burdensome to these patients, and are there ways that we can intervene? Some symptoms like fatigue are notoriously challenging to manage, but others can be worked on, and I think we can find ways to improve.
And Dr. Benjamin Casey.
Thank you so much for this beautiful paper and paying attention to something we don't see often as surgeons. One of the questions I had for you, did you compare your data to other nationally and internationally validated questionnaires that the NIH and the FDA uses that helps us then figure out treatments like the PROMIS or the last out, things like that? And did you look at if there are predictive values in your findings, such as survival, which others have found?
Thank you for that question. That is actually something that we have not looked at yet, and certainly an excellent idea for future direction for this work.
Thank you very much.
Thank you.
Our second quick shot, robotic distal pancreatectomy with splenic preservation and enucleation for pancreatic neuroendocrine tumor in multiple endocrine neoplasia type 1, to be presented by Seth Concourse.
Thank you. So in this video, we present our technical approach to robotic distal pancreatectomy with splenic preservation, as well as pancreatic enucleation in a patient with multiple endocrine neoplasia and multiple pancreatic neuroendocrine tumors. Thank you. So this is an otherwise healthy 16-year-old male with a history of multiple endocrine neoplasia type 1, who was found to have multifocal pancreatic neuroendocrine tumors with increasing sizes. The largest tumor was a 2-centimeter tumor in the body tail of the pancreas. He additionally had 2 prominent lesions in the head of the pancreas. After discussing with the patient and his family, he opted to undergo robotic distal pancreatectomy with splenic preservation if we felt it was technically feasible at the time of surgery, as well as enucleation of the head lesions. So after we obtained adequate surgical exposure, we began our pancreatic dissection. We started inferiorly and posteriorly with our pancreatic dissection, starting medially and proceeding laterally towards the spleen along the retropancreatic fascial plane. And here you can see the large tumor. We then proceeded to divide the splenocolic ligament and continued our posterior splenic hilar dissection to achieve complete removal of pancreatic tissue and all regional lymph nodes in this location. It was at this point where we deemed splenic preservation feasible. We then proceeded with superior pancreatic dissection along the length of the splenic vein and artery using bipolar cautery and clips to ligate any vascular branches. We created a retropancreatic tunnel and passed an umbilical tape. The pancreas was ultimately transected with a staple with reinforcement after slow compression. We then proceeded with dissection laterally, carefully mobilizing the pancreas off the splenic vessels. The key concept here is complete oncologic clearance of lymphatic tissue and the pancreas from the surrounding splenic vessels. We importantly divided the posterior circumferential tissue behind the vessels to achieve this, as you can see here. Ultimately, the distal pancreas was freed from the splenic vessels in the hilum using bipolar dissection. We additionally performed anterior splenic hilum lymphadenectomy, where we had observed prominent lymph nodes on preoperative imaging. Here you can see the completed oncologic resection with the splenic vessels fully skeletonized into the hilum of the spleen. We then proceeded to enucleate the two pancreatic head lesions. We first used ultrasound to confirm these lesions were not abutting the bile duct or the main pancreatic duct, and resected these using bipolar cautery. We ultimately placed a 19 French Blake drain adjacent to both the enucleation sites and the tail of the pancreas. The case itself took 3 hours and 20 minutes, and the patient was discharged in good condition on postoperative day 2. A total of 9 lesions were identified in the final pathologic specimen, with the largest being 1.5 centimeters, intermediate grade with a Ki-67 of 3.2%. All 18 examined lymph nodes were negative for tumor, and the patient is doing well at his most recent follow-up. Thank you.
Any questions for Dr. Concourse?
That's very nicely done. Does your group have any experience with the Warshaw type distal pancreatectomy, where you harvest the splenic artery and vein, but leave the spleen based off of the short gastrics? Thanks.
At least not as long as I've been there, and not that I have seen. I think our most critical consideration, we're very selective with who we choose to do this procedure on, and it's really patients for whom we don't have any suspicion of pathologic lymph nodes, and for whom we think we can carefully clear all lymphatic tissue circumferentially from the vessels and into the splenic hilum. Otherwise, for most indications, splenectomy is something we perform.
Dr. Demure.
While he's coming up to the podium, did you guys do a DOTA scan on this patient?
He did have a preoperative DOTA scan, as is our practice for neuroendocrine tumors. And the tail lesion, the largest lesion, lit up as well as the two head lesions. But as in these MEN patients, we expected to see many small peanuts on the specimen, but they didn't light up preoperatively.
Yeah, I guess that's a little bit of my question, Mike Demure in Newport Beach. Talk about the role of ultrasound and when you resect them, because some people have a size threshold of 2 centimeters or so, and so were any of these functional, or at least on immunohistochemistry, produce a known hormone?
Yeah, so none of these were functional. On preoperative imaging, the largest lesion was 2.3 centimeters. Ultimately, on final pathology, it was 1.5.
And the intraoperative ultrasound?
We performed intraoperative ultrasound to sort of examine the target lesion and the two head lesions, sort of to better understand the anatomy before we enucleated them. Yeah.
Thank you again.
Thanks.
And our last quick shot of the morning, assessment of lymphatic drainage patterns following axillary lymph node dissection with and without use of lymphovenous bypass using lymphoscintigraphy, to be presented by Stacy Sanders from the Mayo Clinic.
Morning. Thank you for having me. We're excited to present our work to you today. We have no relevant disclosures to share. Lymphedema is one of the most feared complications of axillary surgery and results when there's an interruption in lymphatic drainage. As lymphatic volume exceeds transport capabilities, this can lead to swelling, decreased mobility, as well as increase in local infection rate. These sequelae in turn can cause psychological morbidity, as well as a decrease in quality of life for patients. The mechanism underlying lymphedema is not well understood, but we do know that the patient factors listed here do have a strong association with lymphedema. This, however, is only a part of the puzzle. We know that our multidisciplinary treatment of the patient also plays a significant role, with independent contributions from chemotherapy, radiation, and surgery. Axillary surgery carries with it a known risk of lymphedema ranging anywhere between 5 and 20%, depending on the extent of the dissection. Any additional therapies that are added have an additive risk on lymphedema as well. Lymphovenous bypass is a procedure which was designed to mitigate the risk of lymphedema, creating an anastomosis between the lymphatic channels and the venous system provides an alternative means of drainage and also mediates the physiologic mechanisms of inflammation and fibrosis. The procedure is performed by injecting lymphozurin blue intradermally into the volar surface of the mid-upper extremity. Then the axillary lymph node dissection is undertaken. And while doing so, you must pay specific attention to maintaining these blue lymphatic channels, as well as identifying the anterior branch of the axillary vein. Once the axilla is cleared, the vessels are ready for anastomosis. Dr. Jacobs' technique of performing the anastomosis involves using a 9-0-proline suture and placing a U-stitch by going outside in on the vein, through and through in the lymphatic, and then again inside out on the vein. As this is cinched down, it telescopes the lymphatic into the vein. And this is what it looks like at that point in time. The anastomosis is then secured further by placing 2 or 3 interrupted sutures longitudinally, and then securing these down. Once that's been done, you can remove the U-stitch. And this is what the completed anastomosis looks like. Lymphovenous bypass was initially developed with therapeutic intent being performed once lymphedema became clinically evident. Studies looking at the benefits in this setting have shown attenuation of CD4 mediated inflammation, as well as decreased production of TGF beta. Additional findings also include decreased limb volume, fewer episodes of cellulitis, and fewer patient-reported outcomes. Given these findings, as well as findings supporting early intervention, the question of whether or not the procedure should be performed at the time of axillary dissection has also been raised. We don't really know how lymphatic drainage is affected by the procedure per se, but we do have several modalities to study this. Lymphoscintigraphy is particularly valuable in that it provides us with dynamic and static images of the lymphatics, their course, the transit time to the axilla, the axillary basins, as well as collateral flow. On the left here, you can see what a picture of normal bilateral lymphatic drainage looks like. You see tracer being injected in the hands bilaterally, it coursing up to the bilateral axillae and being taken up by those lymph node basins. Conversely, on the right, you see that, again, the bilateral hands were injected, but the tracer only courses up to the right axilla and is only taken up there. So this indicates obstructed drainage. These findings can be further confirmed by SPECT-CT. The study I'm going to describe to you today is actually a sub-study of a larger study that's currently underway. That larger study aims to compare lymphedema rates following axillary dissection with lymphovenous bypass and without lymphovenous bypass. That study is a prospective trial of Mayo Clinic patients requiring axillary dissection. Patients were cluster randomized to surgeon, some of whom perform this surgery routinely at the time of axillary dissection and some who do not. Any adjuvant therapies were ordered at the discretion of the treating team. The first 20 patients enrolled in the study also consented to lymphoscintigraphy scans at 3 and 12 months. These were the focus of our sub-study patients, in which we sought to see whether or not lymphatic drainage differed according to whether or not patients had undergone lymphovenous bypass and whether those drainage patterns changed over time. Our sub-study started with 20 study patients. Two did not make it to the final analysis, mainly because of study protocol aberrations. In the end, there were 11 patients in the lymphovenous bypass group. We had initially intended for there to be a relatively even distribution with respect to surgical group and radiation. However, this was not quite the case. We had about 10% more patients in the lymphovenous bypass group, and about 90% of patients overall underwent radiation. When comparing the two surgical subgroups, we see the lymphovenous bypass group was about 2.5 years younger and had a higher BMI. In addition, they underwent higher rates of chemotherapy in the neoadjuvant setting, as well as radiation, and had about 50% more lymph nodes identified at the time of dissection. The first scans were performed, I should say, at the 3-month mark. And upon looking at this evidence or this data, we see little evidence that performing lymphovenous bypass provided any evidence of improved drainage at this time point. This was shown because there was relatively similar proportions of interruption in lymphatic channels found, as well as similar proportions of mapping to non-axillary nodes. Finally, we looked at these two subgroups longitudinally at the 3 and 12-month time point. Only 8 patients had imaging available at both time points, 6 of whom were in the lymphovenous bypass group. The overall about 75% of patients did not show any improvement in their lymphatic drainage. However, we did find 2 patients who did, and interestingly, they were both in the lymphovenous bypass subgroup. So although somewhat limited by our study sample, our descriptive study does demonstrate that lymphovenous bypass performed at the time of axillary dissection does not improve lymphatic drainage at 3 months. However, there is some suggestion that it may do so as the postoperative interval lengthens. So given these findings, our group recommends further studies that are better powered to assess the outcomes of prophylactic lymphovenous bypass on objective and subjective measures of lymphedema. happy to take any questions.
Dr. Johnson.
Hi, Nathalie Johnson, Portland, Oregon. Thank you for really a beautifully well executed study on something that's really important. It's, you know, I was excited thinking, oh, you're going to have so much more improvement in the patients that had lympha. And you didn't see that, just mild. But what do you think about just axillary reverse mapping just in general for node dissections? In our group, we did that and did a study and showed that just even doing the reverse mapping makes you better in the axilla, so you interrupt less lymphatics. And we did see a decrease in lymphedema. So I'd love to hear some comments on that.
Yeah, sure. I don't think, you know, as part of this study, you know, we don't have exact data within our group regarding just doing the axillary mapping. But I think our sort of gestalt is certainly that doing so, you know, helps us identify the lymphatics and be more mindful of them as we're doing our dissection. Yeah, I think that's pretty much what we think. I also think sort of further support for that sort of mindfulness as we're doing our dissection with the blue dye is that, you know, we're able to actually identify more axillary nodes in the process. I mean, I think our data sort of reflected that. So I think, you know, that's also sort of an indication that performing this procedure is advantageous.
Hi, Kathy Yao from North Shore University Health System. So does it really matter what the lymphatic drainage patterns look like? And maybe development of lymphedema is a little bit more complicated than just the lymphatic drainage patterns.
Yeah, I think the patterns are really only part of the puzzle, because I think, you know, I think what we need from this point forward is to correlate whether the drainage patterns actually correlate with patient reported outcomes and or limb volume measurements. And I think that's what our bigger study seeks to do, is kind of couple the two to see if they actually correspond, because I think that's the most meaningful to our patients and therefore to us.
Dr. Hansen.
Hi, Nora Hansen, Northwestern. Great talk. It seemed as though a lot of your patients that were getting the lymphovenous bypass were in the higher rate. They had a higher BMI. Do you think is it possible could you randomize those patients so that you took that out of it? Do you think that you didn't see the result just because you were treating worse patients with lymphovenous bypass compared to the group that was not treated?
Yeah, the patients weren't obviously like perfectly randomized. But I don't think they were hand selected necessarily to be younger or to have a different BMI. I suppose we probably could do that, but the way our study was set up, it was more that they were randomized to surgeon. So those other factors couldn't be controlled for to as great an extent.
Thank you very much.
Thank you.
And our first oral presentation is modeling survival among child's B and C cirrhotics. Are there subsets that are more likely to survive partial colectomy for neoplasm? To be presented by Dr. Tonelli.
Thank you. Hello, my name is Chelsea Tonelli. I'm a general surgery resident at Loyola University Medical Center. Thank you to the Western Surgical Association for the opportunity to present our work. These are our disclosures. While cirrhosis has been demonstrated to be a risk factor for mortality in patients undergoing non-hepatic surgery, medical management of cirrhosis and a better understanding of disease processes has improved postoperative survival. These risks, however, are often compounded when there is a GI malignancy, such as colon cancer, present in a patient with cirrhosis. In cases like these, a thorough understanding of the specific risks and prediction of mortality are critical to a surgeon. Prior models such as the MELD score and Child-Turcotte-Pugh score have been utilized by surgeons to estimate postoperative mortality in patients with cirrhosis. The Vocal Pen Group has developed a surgical risk calculator that evaluates surgical risk in a cohort of veterans with cirrhosis. This tool uses factors such as age, bilirubin level, platelet count, cause of cirrhosis to predict mortality and hepatic decompensation. One of the variables included is surgery type, of which colectomy is included in the abdominal surgery category. We collaborated with the vocal group to create the vocal Hines score, which specifically looks at patients undergoing a colectomy and included those undergoing the procedure for a diagnosed malignancy. Our model was able to improve on the calibration and discrimination of the child and MELD scores. In building on this established work, we wanted to explore if those patients at the highest risk of mortality were surviving the first 90 days after surgery. We therefore set out to create a risk score that estimates the probability of survival at 90 days in high-risk patients undergoing a colectomy. Our cohort consisted of patients identified in the vocal cohort merged with the VASPIP database that underwent a colectomy from 2004 to 2021. Those with cirrhosis were grouped using the Child-Turcotte-Pugh classification. Patients with a diagnosed malignancy were identified based on AJCC cancer stage. The cohort was limited to those with a predicted 90-day mortality of 20% or greater. We compared multiple prediction modeling approaches to determine which was the optimal method. These were compared using ROC curves and model calibration. The models were also compared in the subgroup of child's class B and C patients. Once the optimal method was identified, a final model was determined, and this was then translated into a point classification system to create our risk score. This scoring system was then plotted to demonstrate the relationship between 90-day mortality and risk score. Our cohort of high-risk patients undergoing colectomy included 711 patients that were alive at 90 days and 322 patients that died within 90 days of surgery. The cohorts were similar in terms of age, sex, and BMI. There were higher rates of hazardous alcohol use in the group that was alive at 90 days. There were also similar rates of cirrhosis and severity of cirrhosis between the two groups. The majority of patients were ASA class 4 and underwent the procedure emergently. Of those diagnosed with malignancy, those with stage 4 disease had higher rates of mortality at 90 days. We also evaluated the preoperative laboratory findings of the high-risk cohort. Those who died within 90 days had higher levels of creatinine, transaminases, and INR. The platelet count was lower in the group that experienced mortality, but did not reach statistical significance. We then compared multiple approaches to modeling, including logistic regression, elastic net, and multiple lasso approaches as seen here. The adaptive lasso method achieved a ROC of 66% and was therefore selected as the optimal statistical approach. In comparing these models in the subgroup of patients with cirrhosis, the adaptive lasso is seen to achieve an ROC of 82%. The calibration of our final model can be seen here, obtaining an ROC of 82%. Using the adaptive lasso method, we developed our final multivariable model seen here. Older age was associated with a lower likelihood of survival to 90 days. Those who underwent an emergent procedure were half as likely to survive within 90 days. A higher INR was also associated with higher mortality. From this model, we developed our scoring system. Each patient starts with a score of 0 and based on the following factors ends with a score ranging from -15 to +8. Younger age at the time of surgery adds to the initial score, whereas older age subtracts. Similarly, emergent status of the surgery or elevated preoperative INR results in the subtraction of points. With this score in mind, seen here is a patient's predicted survival based on their risk score. With a score of +8, a patient has a predicted survival of 99%. As the score decreases to 0, there would be a 92% likelihood of survival. At a score of -6, this likelihood decreases to 54%, and at -15 becomes 4%. Our analysis is limited by selection bias and generalizability related to our veteran cohort, although we also see this as an advantage in being able to visualize a single payer health system where there are medically complex patients. Additionally, there were small proportions of our cohort with cirrhosis and malignant diagnoses that may limit extrapolation to these populations as a whole. Despite these limitations, we believe that our risk score allows for improved evaluation of high-risk patients with greater than 20% predicted postoperative 90-day mortality. This tool can assist surgeons in evaluating high-risk patients that require a colectomy, especially in subgroups with cirrhosis and malignancy. Thank you to my co-authors for their support in this project and to the Western Surgical Association for the opportunity to present our work.
This paper will be discussed by Sandy Cavalucas from the University of Louisville.
Hi, thank you for inviting me to discuss this interesting study building a better predictive model for long-term mortality in cirrhotic patients. I know that it's a large database study, so we may not have the answers that necessarily crossed my mind while reading your paper. Thank you for sending that in advance. But can you give any granularity as far as to the cause of mortality for these patients? I think that it'd be good to know if, especially when you're doing, we don't know the location of the colectomies per se, but as far as anastomotic leak and creation of stoma and hepatorenal syndrome and things like that, if that would, if that has affected, if you're going to say that their mortality is due to the complications of colectomy per se, or just recovering from surgery in general.
Thank you for that question, for reviewing our work ahead of time. I don't think we have an answer per se. I think in working with the vocal group, our hope is to look specifically at cirrhosis and get a better idea. So I think our next step would be, we tried to choose a window with 90 days that would give us a good idea as to they're making it out of the hospital and they're doing okay at home. But then also I think our next step would be looking at hepatic decompensation and trying to understand if the surgery, especially in this case, mostly emergent surgeries, can be done safely and getting the patients with cirrhosis through that period.
Correct, because I think the other question of that too is that at least in the paper, the emergent cases may have been sorted out, but as far as operating on cirrhotic patients for benign disease, the indications for operation, therefore, would be a little bit more interesting as far as taking that risk.
Yeah.
And then the last thing is that you also notice that you're with adding more data points to your score, it's more predictive than the Child-Pugh and the MELD score in general. I think one of the criticisms of the MELD score is that females in general have a better survival than males. When you just look at the MELD score, it seems to not affect them as much. Do you think that in a VA population, obviously 98% men, it's hard to figure that out, but do you think that your scoring system will be able to be applicable to women?
I very much hope so. I think in any VA population, there's kind of like the ups and downs. One side is that you get more information and more often contiguous information. But I think definitely working with this group, hopefully we can then take a look at a different population that has more women and make sure that it's crossing gender lines or sex lines, excuse me.
Awesome. Thank you very much.
Thank you. I'm not running away.
Dr. Joseph.
Bilal Joseph from Tucson. A great presentation. You had age just as a variable based, 65 or older, they get minus 2 points. I mean, was there any thought to look at frailty instead of just age as a marker? I mean, if you had ASA and age, someone could get -4 really quickly. And I don't know if giving a -2 points to a 65-year-old who may be not as sick, even though they have cirrhosis, compared to someone who's 70, who's super sick. I guess age by itself makes it very hard for it to kind of stick out.
Yeah, I think we all see that in our clinical life. There's a healthy 60-year-old and there's an unhealthy 60-year-old, and the difference could be quite substantial. I think hopefully, I know the VA is implementing a lot of measures that look at frailty, and I think introducing it to the EMR as well. So hopefully in the next few years, we will have more factors that can give us a better idea as to the actual overall picture of a patient. Not only do they have kind of the age, the tick box that we can use objectively, but the overall picture of a patient's health.
Mark Telemonte from Evanston and North Shore. Enjoyed your presentation. I think it's an important contribution. I agree with the first discussion. It will be important to know how the patients who had emergency surgery died versus those who had elective surgery, and some of them still died. So sorting out that would help predict how you should help or how you should manage these patients when they show up in the emergency room if they have such a high risk of dying. But my question has to do with the score itself and then the steps to mitigate risk. Predictive scores are helpful because they tell you you're operating on high risk patients, but they're most helpful when they tell you how to mitigate that risk or lower that risk by preoperative maneuvers. And I wonder if you have any data on some of those patients with Child's Class C high risk scores with predicted mortality, and whether or not you learned anything about how to lower that risk, whether it's optimizing diuresis and fluid management, or even measuring wedge pressures and putting TIPS catheters in those patients before you operate. So were you able to sort any of that out in your quality database?
We have not. I think that would actually be an amazing next step to really, we tried to look at like those that we kind of see as like a flip of a coin, like you can take them to the operating room and save them, or are you just pushing them the other way? But I think looking to see if there's something that in our preoperative period can change would be, sorry, I don't have that information yet, but I'm excited at the opportunity to look at it. Thank you so much.
Just giving Dr. Baker the opportunity for any closing comments if he would like.
I don't know that I have anything really brilliant to say, which is not going to surprise probably some of the people in this room a lot. But the score, this was, I think, a really interesting project that's taken a long time to come to fruition. And what we're really trying to do is help the doctor who's sitting there looking at a patient, trying to decide what to do when you know they're high risk. And, start with Dr. Talamante's question first. It was from the beginning meant to give us a risk model, which could then help us look at patients and say, okay, let's TIPS this person and do they do better? And I think we're still, a few years away from doing that. But when we first started looking at this, we just thought that the vocal score was not exactly perfect because they tended to lump people together that had anastomoses, which could fall apart when they're in the context of cirrhosis with people that were getting cholecystectomies, and they were just two populations that were totally different. So I think we're headed that way, but it's going to take us a little while to get there. Cause of mortality is definitely a huge question. The vocal people have another metric that they can use in the big data set to look and see whether or not these folks are actually having decompensation of the cirrhosis or not. And just to give a plug to Vocal Pen, that risk of decompensation is a number that you get when you use the calculator. So I think our immediate next step is to sort of look at these guys and say, what's the risk of decompensation? Is decompensation the reason they're dying, or is it some operative complication, which I think we can get from the VASCWIP data set? Benign malignant question. Our population has a lot of benign tumors in it. We were trying to look for cancer outcomes, but the number of cancers, even in the VA with cirrhosis, is relatively low. So we started with neoplasms, but that are just benign and malignant. We'd like to get to the malignant question because I think that's really the driver. You can't treat these guys with chemotherapy because you're going to kill their liver if you do it. But we've got a lot of benign people in that. So I think that's a legit question, and we'll have to kind of work through it. The frailty question is a good one. The RAI score in the VA is a very accurate determinant of outcome postoperatively. All of the variables that are in the frailty score are in the EDW, almost all of them. So I think we probably adjust for those variables, or try to, in our LASSO methodology. And I think that Chelsea score turns out to be a little better than just the frailty index by itself. I think that's it. I think it's a great idea. Chelsea, done a great job.
Thank you very much. Paper number 2 will be presented virtually. A social needs screening tool facilitates reduced length of stay and total encounter cost for surgical patients, to be presented by Xavier Cortez from UCSF.
Good morning, everyone. My name is Xavier Cortez. I'm a 4th-year medical student at UCSF, and this is my study. A social needs screening tool facilitates reduced length of stay and total encounter cost for surgical patients. My author list is below. Prolonged length of stay after surgery has been shown to worsen patient recovery and utilize health system resources unnecessarily. Also, logistical and social support barriers to optimizing surgical care have been underexamined. In the literature, social needs screening has been shown to decrease reports of social needs and improve health outcomes. Of note, previous attempts at our own institution to improve pre- and post-operative care planning had not been scalable to multiple surgical departments and were therefore unsustainable. This served as the primary motivation for this project. Over the last year, I was studying the impact of a social needs screening tool among patients undergoing surgical care, specifically on patient length of stay and total direct costs of each surgical case. We looked at 7 surgical departments: ophthalmology, ENT, vascular, neurosurgery, orthopedics, plastics, and urology, all over a 12-month period from July 1st, 2020 to June 30th, 2021. Our process was as follows. A patient was scheduled for surgery. Then a staff member would contact the patient via phone or electronic messaging, usually through MyChart. Then the social needs screening tool was administered, which would query the patient's ability to obtain mandatory COVID testing, transportation to and from the hospital for surgery, availability of a post-operative caregiver, and their current mood. If the patient had reported a resource deficiency, then the patient was referred to social work services, and then our social workers would provide the corresponding resource. We looked at 3 groups in particular. Our first group was provided social support that consisted of 180 patients. Our second group, our screen eligible group, consisted of 3,284 patients during the 12-month study period who did not receive social work services. And then our third group, our control group, which consisted of 3,360 patients prior to the implementation of the screening tool over a 12-month period. When looking at the demographics of our cohort, we found that there were no significant differences in age, both average and median, no significant differences in gender, and no significant differences in race among the 3 groups. When looking at insurance type in our cohort, it was not surprising that we have significantly less commercially insured patients, with more Medi-Cal patients in the group that screened positive and were ultimately provided social support. When looking at patient disposition for our patients in this cohort, either discharged to home, discharged with home health, discharged to SNF, discharged to acute rehab, discharged to long-term acute care facility, or elsewhere, the percentage of patients discharged to home was significantly increased in the group that was provided social support compared to the other 2 groups. Also, the distribution of home health care and acute rehab services was significantly lower in those who were provided social support. For our results, I'll direct everybody to the rightmost column, which corresponds with the group that was provided social support. Observed length of stay, both median and average, was decreased in this group compared to the other 2 groups. Also, direct cost per case, both median and average, was decreased in this group compared to the other 2 groups. And this is all while having a similar case mix index, our measure of case complexity, compared to the other 2 groups. Lastly, in this table, there was no significant difference in measured overnight events among the 3 groups. We also took a look at length of stay in patients who received various disposition plans. So we looked at the length of stay in patients who received home health, length of stay in patients who went to SNF, length of stay in patients who went to acute rehab, and length of stay in patients who went to a long-term acute care facility. And I'd like to specifically point out the rows corresponding with the provision of home health care and acute rehab services. There appears to be around a 20% increase in length of stay for patients who are provided social support compared to the other two groups. Now I'll bring back the patient disposition demographics table that I had mentioned earlier. As a reminder, the percentage of patients discharged to home was significantly increased in the group that was provided social support compared to the other two groups. And also, the distribution of home health care and acute rehab services was significantly lower in those who were provided social support compared to the other two groups. So to summarize these two tables, while patients who were provided social support services received a significantly decreased percentage of home health care and acute rehab services, those who did had around a 20% increase in length of stay. Therefore, patients who were screened either were discharged to home or required fewer discharge resources. Now, those who actually required home health or acute rehab in this group were possibly more socially complex, requiring a slightly longer hospital stay to connect them to the proper resources. Some points for discussion. This social needs intervention was designed to be scalable so that it could be applied to multiple surgical departments, which should make the program more sustainable over time. Additionally, the timely provision of resources through screening, such as the referral to a postoperative caregiver, disposition plans, or transportation arrangements, which in our patient population was actually the most requested resource, may have accounted for the reduced length of stay. Also, reduced length of stay or the total avoidance of hospitalization in general may have contributed to the decrease in total direct cost per case. Overall, the social needs screening worked well in our target population, a population that is known to require more social needs and consume more resources. So in conclusion, the implementation of a social needs screening tool to proactively address logistical barriers to care reduces length of stay and total direct cost for surgical patients, optimizing comprehensive healthcare delivery. Thank you for the opportunity to speak at WSA 2022. I'd like to thank Dr. Thomas Chi for his mentorship throughout this project and his presence here to assist in closing my presentation. I'd also like to thank Dr. Ajay Maker, a WSA member at UCSF, for sponsoring my presentation. And lastly, I'd like to thank Jill at the WSA for helping facilitate my presentation over Zoom. Thank you all once again. I'm happy to take any questions.
So our presenter, closer and sponsor are joining by Zoom. We'll have our discussant and then the other questions from the floor all proceed at once, and then have the closer answer those questions all in a row. And the discussant is Dr. Saba Ganai from the University of North Dakota.
Thank you. And thank you, Mr. Cortez, for your presentation on this important subject. So social determinants of health are conditions in the environments where people are born, live, and age that are facilitators and barriers to optimizing function, mental health, and physical wellness, and can ultimately impact longevity and quality of life. These conditions stem from social and community context, economic stability, education access, neighborhood and built environment, and healthcare access and quality. Now, social determinants of health and social needs are indeed interrelated, but are distinct concepts. The former being focused at care from a population level, while social needs are defined by the individual context. From a pragmatic focus, social needs are problems with solutions. And while they do require resources, many of those may be able to be integrated into the perioperative workflow if done systematically and strategically. So my first question comes to the screening tool. A good tool should be parsimonious, comprehensive, and multidimensional, short and sweet, but also able to capture reasons that patients will fall through the cracks. Can you specify how you chose your screening tool? And you mentioned that transportation was the most important component, if that is the area that we should further put a greater focus. The second question has to do with the presence of social support. And from the cancer literature, there's good data showing better outcomes amongst the married and the coupled as opposed to solo individuals when faced with complex care. Can you further elaborate on the marital status of your cohorts? My third question has to do with the use of historical controls, which were pre-pandemic. Is it implied that, first of all, no patient in the control group was provided social support? And was this confirmed retrospectively? Fourth, the control group did have a decreased cost, which was could be attributed to that length of stay of 1 total day per patient. Could this also be confounded by changes that resulted from the pandemic and not causally related to additional social support? And then finally, on that line, when you did control for case index, and at least in the manuscript, this led to an increased CMI adjusted direct cost with the screened cases compared to the historical controls. If you could kindly explain that. Thank you again for the opportunity to review your paper.
Dr. Joseph.
Great paper. 2 questions. One, maybe I missed it. I didn't see general surgery as one of the departments that was reviewed, or to my feelings, trauma either, which I think are the 2 populations which have patient population you're trying to impact. And then second, you mentioned transportation as one of the key things that maybe reduce the length of stay, having people pick them up. And in Tucson, sometimes we get people that are 2, 3, 4 hours away. Do you have the average time for transportation for these patients, how that is impacted? Because I think if you're going to, your conclusion was we're going to apply it to other departments, but some people are really restricted by geography, and people travel long ways to get their surgery. So I would like to know how that you plan to work that out.
Right, Mike?
Yeah. Jim Jacob, Mayo Clinic, Florida. So I was a bit concerned about potential confounders, and I didn't hear you mention, did you control for type of surgery the patients were receiving? And I wonder, 70% going directly home versus the other groups is pretty striking. So I was worried about difference in operation they received. And is it possible that patients who don't have commercial insurance and have Medi-Cal, it's simply not possible to get them acute rehab and home health, and therefore it's not even attempted?
And I have one question. The median length of stay median and mean length of stay actually seemed fairly short. And that may refer back to Dr. Joseph's question that general surgery was not included. And so I wonder if you can comment on the complexity of the procedure. Maybe these were not particularly complex procedures, or what we would call complex discharges. And Dr. Yao is at the mic as well.
I had a question about how many patients actually responded to the MyChart or the phone call to fill out the screening tool, because that's a big problem we've had, is getting patients to actually comply with these questionnaires.
All right, several questions, Dr. Chi. If you can do your best to address them, and thank you for being available by Zoom. Appreciate it.
No, we really appreciate the opportunity to be here, and thank you so much for having us in these great questions. So I'll start from the top. I did kind of take some notes as we were going. So the first question was really around the screening tool itself. How did we choose the screening tool and kind of design it? And clearly, as has been mentioned by several folks, transportation was something that kind of came up as one of the most frequently seen barriers to people being able to have reasonable outcomes. So the screening tool itself, the actual kind of how we came through this was through a Caring Wisely project. So it was an institutional competition. Many institutions probably have a similar thing, where the health system was looking for ways to get kind of bang for your buck and reduce healthcare costs. So this project was initially a Caring Wisely project. It's been sustained since then. And so as part of the Caring Wisely team, we actually sat down initially with our social workers to talk with them and ask, well, what are the actual issues that come up the most often for you? So how can we together collaboratively design a screening tool that you think will pick up on the biggest red flags? And so they're the ones who identified family support, transportation, people at home after the surgery. So that was kind of a back and forth that took a couple of months to really figure out, okay, what do we think are the highest yield targets? So it was a nice demonstration, I think, of where physician, patient, and then the people who actually do the work, the social workers, kind of coming together in a collaborative fashion can help to design interventions that have a high impact. And I totally agree with the comments around determinants of health and social needs being interrelated, but not the same. It's very true because the social determinants of health, some of them unfortunately are not alterable in many ways, especially in a perioperative circumstance. And so having that social work interface, I think, was critical for us. The question about marital status, so data is showing that marital status has really impacted cancer outcomes. And do we know about marital status? That's a great comment. It is in our EPIC system, and I do a fair amount of work through the EPIC system here at UCSF, and we probably record it maybe a third of the time. So great comment. We didn't actually look at that specific thing, but I do think it's worthwhile for us to go back and pull that data out. It'll be incomplete because it is one of those things that we don't zoom in on. Like 100% of people have a tobacco status question answered because it's a requirement before you can close the chart out, right? And all of us know that the pain of closing the chart out is what drives a lot of compliance. So marital status is not a requirement, but it's probably picked about a third of patients. So great comment. We'll take that back to try to look at that. I imagine that it will have some level of impact on how we look at people's social support at home and whether or not that impacts length of stay. And the question that came up about the controls, do we really account for pre-pandemic versus post-pandemic? Totally recognizing that we created this pilot program right in the middle of the pandemic. And so we were too concerned about whether or not the pandemic would play a big influence on this, which is why we designed it to be historical controls, which were pre-pandemic. So we wanted to look to see, is what we're seeing an actual pandemic issue? But our actual control, in my mind, that really would highlight whether or not this is a pandemic issue or not, was that we took the screen eligible patients during the pandemic. So these are the patients that we screened just altogether during the pandemic. And then the ones that screened positive became our cases. So that's the 160 or so patients that we actually used who got social support screening. So by designing in two control groups, a historical control to look at pre-pandemic effects, and then the screen eligible patients, those are the ones that were during the pandemic that we looked at, but did not get screening, did not screen positive, so didn't get any social support. By using those two control groups, we think we accounted for pandemic effects. And what was interesting out of that comparison is that, as you can see from the data, not really much of a difference in terms of case index or length of stay between those two groups. So clearly the pandemic was a big impact on many of the things we did at all hospitals. But at least in this particular study for these services, it did not seem to impact things independent of what was happening with the social support screening. I'll come back to the comments around kind of the complexity of care, because I think it probably relates to this particular issue. And it may be that just because we looked at these specific services, we might not have hit some pandemic effects because maybe these particular services had less of an impact, because that was also heterogeneous, as we all know, throughout different hospital systems. And then the last comment, I think, around controlling for case index. The case index was a challenge, and I'll kind of extend into the comment by Dr. Jacobs about the type of surgery and whether or not we controlled for that. The case index is something that is automatically linked to each case when they are booked through the EPIC system. And so it's a marker that's in place that is easy to get to, but may not really speak towards all of the subtleties around actual case complexity. So as we all know, I'm a urologist, and so one of the things that we'll do is stone surgery. But there's stone surgery and then there's stone surgery. And even though you might do the same surgery for some patients, it could be quite a bit more complex with quite a bit more complex patient in one instance compared to another instance. And so the controlling for the case index was the best that we could do because that data was readily available in Epic, but we definitely recognize that it may not capture all of the subtleties around kind of patient complexity and then surgery to surgery complexity. Along those lines, some of the later questions from Dr. Jacobs and our moderator, thank you for asking those questions around kind of the type of surgery and the inclusion of general surgery. This was a pilot project, and as I mentioned, it came from a Caring Wisely program. And so one of our big determinants of which services we wanted to include was we wanted to get to services where we'd have good engagement, because ultimately being able to put an intervention in place that was a pilot with a very small budget was that we wanted to make sure we'd have the highest amount of interplay between our team, the social workers, and then the services that we thought would actually engage in putting this pilot in place. Because ultimately, the intervention came at the level of the navigators, who are the schedulers in our case. And so in order to get compliance up, the first part of the implementation portion of this project was really talking to navigators on a weekly basis. So we had to make sure, okay, we've created this social screening thing. We think it would be great if it was automated and put in Epic, but navigators, tell us what you can actually do. And so for some services, phone calls was the way that their workflow worked the best. In other services, the use of MyChart messaging was the way that they thought they would use the best. Some people even use texts. But our selection of the services was really driven, again, with the social workers to identify which groups have historically been the most engaged in these types of conversations so that we could actually implement something successfully in a relatively short turnaround. So that being said, absolutely agree with the comment. We did not include some of our services which have the most complex types of cases and the longest length of stay, cardiothoracic surgery, general surgery. These services probably do utilize a larger amount of social work services over time, but the decision to not include them was not about excluding them, but rather about focusing on partners that we thought would actually be able to quickly and more nimbly implement something that could be used for screening purposes, and we could meet on a regular basis around it. In later iterations, we certainly think that this is scalable, and moving towards those other high target, high value care services, I think will be important for us, Department of Surgery and Thoracic Surgery. So great comments. And right now at this particular point, we don't know what that impact would be if we go to those more complex services. And the last couple of questions that kind of came into play, how did that complexity then play into the median length of stay? And the median length of stay was pointed out by the moderators, relatively short compared to many services. Absolutely see that as being an issue with this particular study, in that the services that we did end up picking, because of that kind of practical consideration, they tend to be a little bit less complex. Orthopedic surgery, no offense to any orthopedic surgeons, but those patients do tend to go home and they've got kind of more of a pathway type care compared to maybe some more complex surgeries like hepatobiliary surgery, for example, or other services that might be more complex or require longer lengths of stay. But we did try to control for that by using, again, those two control groups compared to the one case group. So even though these are shorter lengths of stay, we could see with the pre-pandemic control group and the inter-pandemic control group that screened out and did not require social needs, their length of stays, even though they were short, were still similar. And so we do still think that the actual screening tool and the patients that screened positive did have an impact on length of stay. And there was another great question around, how do we know whether or not they had social work resources used for patients in the control group? Absolutely correct. So in the pre-pandemic group, patients did get social work because that's just a thing that happens in the hospital when patients are identified in inter-hospital stay. And the amount of social work needs that were provided to was increased in our screen positive group. So, that makes sense. As they were screened positive, they were offered social work up front. And because we could plan a little bit ahead of time, things like rides, for example, is a great example. Because you could plan for those up front, it was easy to isolate those resources and give them to them. So in our screen positive group, they did utilize those resources at a higher rate compared to the control groups, but that was intentional, of course. And so in the two control groups, they did get social support, just not at a high rate compared to our screen positive group. And then the last question I had was from Dr. Yao around the patients who responded to my chart and phone calls to fill out the screening tool. I would say that of course, these are patients who tend to be less commercially insured, so probably are underserviced and are under-resourced patients at baseline. So phone calls tended to outpace the use of my chart, but my chart was a starting place where people sent messages first, and if there was no response, the navigators would then reach out with a phone call to do a follow-up. So in those 3,300 patients or so, they did screen them all. And so they got to them some way or another. And they started with the messaging, but especially in the patients that screened positive, phone calls did tend to get to patients more often because these, again, are our most vulnerable patients. And I hopefully got to all the questions, but of course, we're happy to take more.
We will have to go on because of time. Thank you very much. And Mr. Cortez, a wonderful presentation.
Thank you so much for having us.
Our next presentation is an OUST Award candidate, which is the best presentation and paper by a new member. Differential gains in surgical outcomes for high risk versus low risk pancreaticoduodenectomy with 3 successive refinements of risk stratified care pathways by Qingwei Zheng from MD Anderson.
Great. Thanks so much for this opportunity. And certainly I want to point out all the fellows who came to the meeting and also who helped with this project, including Rita Yabe. So I'll take you back to a long time ago before the pandemic, 2015, not that long ago. And you might say, well, we were doing pretty well, just fine, you might say, but we were quite stagnant in our median length of stay for our Whipple patients, about 10 days, which is the meniscus median. Of course, everybody knows that enhanced recovery pathways had always worked in other disease sites. So we decided to analyze our own cohort of patients rather than borrowing from outside institutions, their data, and created 3 strata for our outcomes, specifically the outcome of postoperative pancreatic fistula. We use a color-coded system, so it'd be easier just to speak the same language as we discussed among our providers. The first pathway was rolled out in October of 2016, and we measured and reevaluated for several iterations over the last 6 years, and that's the point of this study today. We've all seen cycles and figures like this in which we talk about the learning healthcare system, in which we go through this, find a problem, we analyze it, we come up with targeted interventions, we roll them out, and we measure them and publish them. And I think everybody's done this. The question is it worth the pain to go through the cycle again and again and again? Going back again to 2015, what we did is we looked at our own Whipple patients and we looked at what their histology was, we looked at their BMI, and we looked at the duct size and created our own risk score. Of course, having 5 risk scores would be kind of ridiculous in terms of a pathway, right, for postoperative care. So we try to group them together into a low risk green color, so kind of like a green light, go quicker, and a high risk orange group. So we have just 2 groups. And the third group we're not going to talk about today will be for the distal pancreatectomy group. Again, risk is defined as a fistula. So just as this has been published before, but you can see here the scatter plot in the control group before these pathways were rolled out. You can see the blue dots are all over the place. And across the bottom on the x-axis, you'll see that this is the age of the patients. And certainly the older age would stay longer, and all the dots were everywhere. On the pathway for the first year, you can see that regardless of the age, everything was clustered around the median length of stay. So this is pretty obvious. And these are in the low risk patients. So you can see that the immediate savings come from these low risk patients who can be fast tracked. You can see that the interquartile range bar is much smaller, and the median, of course, dropped from 10 days down to 6 days very quickly. But then if you look in the high risk Whipple patients, there was no change in interquartile range. So that's the question. Is it worth it to go back through the cycle again? So the objective of this study was to evaluate the gains we made through the various iterations. And here we had our 3rd iterative process this past summer. So in version 1, we had 3 color-coded handouts like we talked about that we gave out to our patients and to the providers. For example, I'm going to point out one thing. We'll just focus on NG tube removal, for example, which is a controversy among general surgeons who do this operation, and very conservative length of stay targets. Then in the next iteration, we had new drain amylase cutoffs. In the first iteration, we borrowed outside institution cutoffs because we had to have something to start with. But then we analyzed our own cohort because all of us operate on different types of patients. And then we inched closer on removing the NG tube by day 2, for example. We instituted an opioid reduction protocol and further reduced the length of stay targets. By version 3, we finally agreed on removing the NG tube, for example. Again, just pointing out one thing on post-op day 1. Of course, that was not possible even 4 years before, but finally people agreed to this and further reduced the length of stay targets, and this is the study today. So our hypothesis is that the low-risk patients experience immediate or so-called fast-track gains with initial pathway implementation, and that the brakes are removed. We're the ones, as the providers, putting the brakes on some of these patients who really can't be fast-tracked. But the high-risk patients are the ones requiring this learning health system model of iterative improvements. So this is a single institution retrospective study, but it's through a prospective database. And what I mean by that, bi-weekly, 1 faculty and 2 APPs review all the outcomes of our patients up to 90 days as we close the books. So 90 days when we close the books for their surgical outcomes. The pathway is revised in the chart I showed you before. The primary outcome of the study is length of stay, but I'll point out specific things that are pancreas specific, like readmissions, major complications, delayed gastric emptying, and fistula rates. We had 481 patients over 50 months. So you can see the point of this is not to have any p-values, which I completely left out on purpose, is show that there's a decent sample size here, and it doesn't take a huge amount of time. If you look at the longitude of this time, the study, to make a lot of implementations and changes. So here's the primary outcome. If you start from the left side, you can see version 1, version 2, version 3. Green, again, is the low risk. Orange is the high risk patients. And look in version 1, you see the immediate gains in the green, the length of stay dropped down to 6. And in the orange patients, it was still quite high, around 9. And the scatter plot was, again, still all over the place. But what I want you to notice is that the interquartile range is coming closer and closer together. Of course, the greens come down by 1 median length of stay per day across there. And you can see that on the right side, where by the 3rd version, as we analyze this summer what we've done in the past 5 years, the length of stay, even in the high-risk patients, is now half of the low-risk patients pre-pathway. And the point of this curve in figure B is to see how the orange pathway patients, the high-risk patients, take a little bit longer to follow what happened very quickly in the green. But with the work put in with these cycles, which is actually easier and easier with each cycle, paradoxically, you can get to the point where, amazingly, it's equal now to almost low-risk patients. So of course, anytime you talk about length of stay reduction, you have to talk about readmissions. And of course, you don't want any reflexive readmission. And there's no change in our readmission rates over time. And certainly this is another project. And readmission rates can be different at different institutions because of your threshold and whether these are actually captured at your institution or captured at other institutions, because your patient may not be admitted at your hospital. But we've tracked these patients down and we called them at 90 days to make sure they weren't readmitted somewhere. You can see in the high risk orange color patients, there's a stepwise reduction in major complications as well. These are graded by accordion scale. So this is greater than equal to 3. So any interventional complications. And so this has come down over time. The green patients, of course, remain relatively low because they're low risk to begin with. NG tube, again, a major point of contention among all general surgeons. So we just measured the compliance in removing it by day 1. Of course, in version 1, very rare, 10% of the time, were NG tubes removed on post-op day 1, because in fact, the very first version asked for it to be removed on post-op day 3. So the ones being removed on post-op day 1 were by the surgeons crazy enough to remove it on day 1. So you can see that without the number one thing people complained about at the beginning and removing the NG tube on day 1 was potentially more DGE. But in fact, you can see that the DGE did not go up, delayed gastric emptying, but in fact, the DGE actually went down in these high-risk patients over time now that we get the NG tube out and get the diet moving along. Finally, we'll talk about fistula rates. So there's a steady increase in the figure on the left of drain removal by day 3. We'll call that timely drain removal. As we all know now, removing the drain on time is extremely important, and leaving it longer is associated with more leaks, actually. And so steadily, we've been able to remove the the drains by post-op day 3 or by post-op day 4, which is not in here, but you can see in the orange ones we've gone up. And as we've done that, of course, the greens on the right side remain low because the risk score for that is extremely low for a leak. But the orange high-risk pathway patients have come down in their leaks dramatically. And, the other thing is, this is a scatter plot of when the drain is removed. So you can see in version 1, again, the emphasis was just kind of having at least some guidelines for postoperative care and a target for median length of stay. There was not a huge emphasis on timely drain removal. So the scatter plot is all over the place on version 1. Even version 2, as we started getting our own drain fluid amylase cutoffs, still not quite there. And finally, between version 2 and version 3 is when we said, okay, we must check it on post-op day 1, post-op day 3. We are going to follow our own patients' drain fluid amylase cutoffs that we published. And you can see here that the scatter plot is much tighter. The interquartile range is dramatically different. And of course, we're having more patients getting their drain out. And that you saw on the previous slide is associated with less leaks. So I have 2 summary slides. This is summarizing the study. And this is pretty obvious, I think, that immediate gains were experienced in the low-risk patients who could be fast-tracked. So that's number 1. So this makes it worth it, number 1, because most of your patients probably are these fast-trackable patients, which about 2/3 of our patients were. But the successive refinements of risk-stratified pathways have led to reduced length of stay, reduced major complications, reduced DGE, and reduced fissure rates in these high-risk patients. The other thing I have to say is that these gains in these high-risk patients did not take that long. This has all been done in 5 years. So that's the key. A lot of people think this is going to take a long time, but if you just look at it every 18 months, it's really not a big deal. And this is a nice slide that our fellow Rita Yabe came up with. And you can see people have to ask, well, where should I start? This is easy, not too difficult. And I didn't say difficult because that might be discouraging. On the red slide, I said it might take multiple iterations. So I think it's pretty easy. For patient education, handouts to be done, bowel regimen, ambulation, IV fluids, that kind of stuff. So it takes a little bit of negotiation between your own providers and anesthesia is the use of regional anesthesia, non-opioid bundle. And finally, the parts where the sticking points were for us were the NG tube removal, diet advancement, and the drain removal. Thank you.
This paper will be discussed by Michael Egger from the University of Louisville.
Good morning. I'd like to thank the Western Surgical Association for the opportunity to discuss this paper by Dr. Zung and colleagues that really should inspire us to evaluate our own clinical programs and look for opportunities for improvement. The authors describe the 5-year evolution of their risk-based postoperative care pathway at MD Anderson. While the pathway itself has been described in more detail, the focus in this report is on the marginal improvements that come with each iteration and revision of the pathway. The immediate postoperative complications that need to be minimized after a Whipple resection are postoperative pancreatic fistulae and delayed gastric emptying. Certainly, one complication begets the other, and these are the 2 main issues that prevent timely discharge and were the focus of this study. What I find interesting in this paper is that the authors were able to actually reduce the rate of postoperative pancreatic fistula. They essentially cut it in half in the high-risk patients from 33% to 16%. Now, in full disclosure, I likely contributed to many of these early fistula in the initial group when I was a fellow there, and my graduating from the institution seemed to have been part of the iterations that changed. The authors were kind enough to leave this out, and I appreciate their discretion. But really, the reduction in the fistula rate, I think, is really promising evidence that it's actually a modifiable risk factor. So instead of simply sort of shrugging our shoulders when we have to do the Whipple on the patient with a neuroendocrine tumor, a tiny duct, and a butter soft gland, maybe we can actually do something about it. And what's really intriguing about the study is it's actually the postoperative care is where we might be able to do something about it. So the paper is a great example of rolling up your sleeves and constantly seeking to improve your own program. As mentioned in the paper, quality improvement is an iterative process. And it shows how continuous quality improvement can be used to evaluate and revise your programs. Reducing variation in large volume, multiple surgeon programs is possible. And I'll certainly leave this paper on the desk of my partners as we look to evaluate our own programs. I have 3 questions. What were the differences in the revisions for the low and high risk pathways? Were you simply making the high risk pathway look more and more like the pathway as you sort of gain the confidence and courage to accelerate their recovery? Or were there specific changes that were specific to the high-risk group? Particularly, were there any changes in your surgical technique to pancreatic jejunostomy? Second, what tips do you have for us with regards to implementation? Did you have surgeon champions, APP champions, things like that to help move things along? And finally, did your near-term post-discharge management of these patients change to keep your readmission rates steady? Are there elements of the pathway that occur in the post-discharge setting that change and that we need to know about? So again, I'd like to thank the Western Surgical for the opportunity to present this paper, and I congratulate you on a well-written manuscript.
We'll go with a question from Dr. Schmidt and then Dr. Kubi.
Thanks. Very interesting paper. Did you guys look at controlling for surgeon or experience of surgeon? Because I mean, one of the most obvious things you might think of when you look over a long period of time is you guys just got better. You know, you were technically better, you were quicker, you were more selective, appropriate patients, that sort of thing. So.
All right, Dr. Schmidt took Dr. Kubi's question. We'll go to the right and then back to the left.
Hi, Steve Curley, Chingway, nice paper. Two things. One, I just want to validate your results. So I've been in my current position for the last 4 years now in a large community-based hospital practice. And one of the first things I did is initiate ERAS pathways across all oncologic operations. And we've done about 250 Whipples in the last 4 years. And we have taken our median length of stay from 13 days to 6 days. I kind of skipped your first 2 iterations. I went right to post-op day 1, pulling NGs right from the get-go, which freaked everybody out. But it essentially can confirm, we've not yet published the data, we're still collecting it, but it essentially shows the exact same thing. And so that really leads to my only question, which is somewhat similar to the previous. How do you take this data, which is performed in a large academic center, and translate the importance of these sorts of pathways out throughout the country? Because these sorts of cost savings, length of stay savings really are going to be more and more important, are going to be things we're looking at. How do you think we can implement this on a national scale? Thank you.
Dr. Ganai, Dr. Shoup, Dr. Trudy, and then we will close questions.
Thank you. Can you elaborate more on your fluid management, not just intraoperatively, but when you discontinue IV fluids post-op?
Margot Shoup, Orlando, Florida. A little bit along the lines of Dr. Curley's question. As you know, Medicare has DRG implemented geometric mean length of stay for these patients. And my guess is you're actually doing great with these. You're far under what those GMLOS is for Whipple fit patients. So my question to you is, have you looked at the actual cost savings and revenue benefit that you have just from putting these protocols in place? Because I think if we can demonstrate that, then everybody else will be able to more than easily justify having a staff to help put these things in place. Thanks.
Thanks.
Chingway, great stuff from you and your group as always. Mark Trudy, Rochester, Minnesota. You're looking at high-risk patients, which we're defining as patients who are going to get a grade B or C postoperative fistula. So it's something we have to intervene on. You showed that you've dropped your median length of stay to 5 days in those patients. Aside from a small percentage of people who get really sick really fast, most of these leaks occur beyond post-op day 5. You did show your readmission rate, and you said it was not significantly different statistically, but it did appear to be rising. So how do you account for patients who develop leaks later? Are you capturing these people? You see a lot of patients from other states. Are they being readmitted elsewhere that you're not aware of? Thank you.
Dr. Zhang, will you close?
All right, that's quite a test here. All right, see if I took good notes here. We'll go backwards with Trudy's. All right, so yes, for sure, leaks happen after the early discharge, and you can miss this, but so this actually goes to the third question from Dr. Egger as well. We do a 24 to 48-hour phone call at after discharge. We see them within 7 days of discharge from the hospital. So if you add 7 to the 5, so in general, they're going to be seen in this first 10 days. And so we are going to capture these people when the highest risk is happening at 7 to 10 day mark. The other thing to point out is that even as the orange patients are becoming more greenish in terms of their pathway care, they still remain orange underneath. And that means that a white count of 12 should be respected, while a white count of 12 in a green patient can be dismissed. So I think that's the key difference, is that we were able to remove the brakes over the many years, and that we saw that orange pathway patients could have the handcuffs taken off and keep on moving along. But a white count of 12 on post-op day 7 should be more respected in an orange pathway patient than one in a green. In terms of the cost savings, yes, that's a project we're working on right now that hopefully will turn into SSAT. And yeah, geometric mean length of stay is a major thing in Epic. It's on our, when we pull up the screen, the home screen in terms of what it is. And it's like a countdown as y'all, if those y'all have Epic. And so we are working on that. IV fluid management specifically, this is very tied to opioid management. As long as you're on IV fluids and not eating, this is all tied together in dietary. So if you're not eating, you're of course on IV fluids and you're of course on a PCA, and this only makes things worse, right? So by getting the diet started, you can start taking oral medications and get off the PCA, get off the IV fluids, start taking oral. So all three are tied together, the IV fluids. And so we cut off the IV fluids by post-op day 2, to put it short. By post-op day 1, you go from IV fluids of going from like 100 cc's an hour down to 40, what we call KBO, and by next day is down to 10. And then once the PCA is off by day 2, then it's 0, other than any medications that might be going. To Dr. Curley's point, how do you translate this to the whole country? That's hopefully the point of some of the summary slides, and showing like what is the easy stuff to work on first. I've had other providers from other institutions ask me, where should I start? And instead of giving them our version 3, or now we're version 4, I give them actually version 1, which might seem like prehistoric with the NG tube out on day 3 and things like that. But it points out how, the key here to get things started is that you don't need 100% agreement on every single sticking point. Otherwise, you will never get started. And so, for example, it was just on a Word document at the beginning. Now it's on our iPhone app, but it was on a Word document before. And some things were bold as required, like PPI prophylaxis, the IV fluid stuff, the PCA stuff. And some was just regular font. So an example would be Reglan. We're not going to fight to the death about Reglan, right? So there's things that you should agree on, things you can just move along with. In terms of the changes in surgeons, I think that's the advantage of the study. This all happened in 5.5 years, but had the same surgeon. So there's no difference in our technique. Our PJ technique has been the same. And so that is really, this is all from, I think, post-operative care being improved and standardized. And then going to Dr. Egger's questions, just starting at the top, is simply the orange patients getting more green light in their care? Again, the answer is yes. There's no change in the surgical technique. There are commonalities between the two pathways in terms of their the to-do list, so to speak. The sticking points again at the beginning were the drain management and the NG tube, and I think that's where you kind of have to back off. There are always more aggressive surgeons say, "No, this is ridiculous. Why don't you take out the NG tube on day 1 or whatever?" Just calm down and just start somewhere, and together you'll get there. Even with opioid management, that took a few iterations, but by the second iteration, we were able to get there. Again, I think the key to remember is that underneath it all, I said it at the very beginning, a high-risk patient is still a high-risk patient. So even though they're acting more green and you see how the median length of stays have come down to almost match each other, you have to respect the underlying issues of a high-risk patient. The stakeholders are the most important here. So the attendings seem to be the ones who do the rubber stamp for saying yes to implementing the new pathway, but ultimately the ones who are taking care of the patients on the floor are the residents, the fellows, and APPs. So every 18 months or so, we're coming together, reanalyzing your data. We have report cards that we give to all the surgeons about how their outcomes are. And that's key too, because the surgeons won't believe it until they see what their actual outcomes are. And then they see the conglomerate and they see, oh, well, maybe my DGE rate is not as good. What is different? Well, maybe we should take out the NG tube on a certain day. So this is how it led. Instead of us forcing the situation, you lead people to come to the conclusion that we should move forward. And the APPs and fellows are the ones who notice these changes and put into the next. Our most recent change this summer had only 3 track changes on the whole document. So it gets easier and easier. At the beginning, there's 40 things. It was ridiculous. And then in the discharge stuff, I answered that question in the beginning, just standardizing the phone calls and making sure you keep a track on the patients. Thank you.
Thank you, Dr. Sang, and thanks to all our presenters. We are a break back at 9:15. Please use a short break to visit the sponsors. You'll hear later how important they've been in our ability to put on this meeting.
Oh, okay.